Thanks, Karen. So I'm going to talk with you today about a body of work that we're doing within the Queensland Paediatric Cardiac Service, looking at establishing a statewide approach to supporting neurodevelopment. So this is a body of work that sits independent from the Fontan registry, but I think it has the same philosophy of wanting to understand and improve and support the lived experience and the functional health outcomes for people with congenital heart disease. So we know there's been significant advancements and improvement in surgical outcomes for all children with congenital heart disease, as well as those with complex lesions. And there's been a shift then in looking at understanding not just what improves the quantity of life for people with congenital heart disease, but also the quality. And we've recognised today, that there are a lot of people who are living very good lives, but at the same time, if you have congenital heart disease, you're at a higher risk of having poorer neurodevelopmental outcomes, and also at risk of needing additional supports around that, including educational supports and allied health therapies with established developmental delays. So it was only 5 years ago that the American Heart Association... Is this a little bit buzzy? Is it okay? Okay. Let's just be up here. So it was about 5 years ago that the American Heart Association established through the scientific statement, established some guidelines and some recommendations around evaluating and managing neurodevelopmental outcomes for people with congenital heart disease. And that involved identifying who is most at risk, and broadly speaking, that's anybody who's had open heart surgery within the first 12 months of age. So in response to this, in 2013, with the support of a Heart Kids grant in aid, we were then known as the Neurodevelopmental Long-Term Follow-Up Program, now a CHD Life program, and we wanted to establish a pilot program that looked at better understanding and supporting neurodevelopmental outcomes. Initially that was for 3 cohorts of children, and that included all children in our service who had undergone a Norwood procedure. So since the program started, we've enrolled over 100 children, including the lovely Mitchie there, having his Bailey's assessment, and have undertaken over 100 face-to-face assessments, and in our current model where we're screening, including using telehealth, over 40 assessments. And during this time we were able to understand that the children coming through our service have similar outcomes in terms of their neurodevelopment and quality of life as is seen in international programs. What we also realised at this time is we're limited to 3 cohorts. This really needed to be expanded to all children who are established at being at risk, and so that's all children who have surgery under 12 months of age. During this time we also moved hospitals from the Mater Children's across to Lady Salento. And as Eve's mentioned, there was World Congress a few weeks ago now in Barcelona, and it was lovely to see a whole day dedicated to understanding neurodevelopment across the world community. And what was really interesting to hear is that for all the services who have been able to establish a program, everybody has faced significant challenges to the sustainability of their programs, and this is primarily due to funding. So to look at improving the sustainability of our program, we started a conversation with the Queensland Child and Youth Clinical Network. So they're an independent Queensland health body, and they work with health services that are focused on infant and child health, and they work with services to drive and to help them grow their services. So what started as a conversation looking to improve the sustainability of our program turned into a successful funding application for a 2-year project looking at establishing a statewide approach. So this has been a wonderful partnership with the network. We also have used iCare, which is a Children's Health Queensland project methodology for clinical service redesign. And what that essentially allows us to do is to have a really robust approach to looking at this. And it also inherently has executive buy-in and endorsement, which has been very important. Queensland is a very large state, and as we've learnt along the way, we have 16 hospital and health services that are all run independently. So we thought that as we started this project, we needed to have other additional trial sites besides our own of Children's Health Queensland. So we've chose Ipswich Westmoreton. We wanted to choose a hospital service that was close by. Sometimes children who are seen, who live within Ipswich Westmoreton HHS move very readily between Children's Health, Lady Salento here and Ipswich. And also we wanted to choose a rural and remote HHS as well. So Cairns and the hinterland area, also because it has a large Indigenous population, and it was important that we also considered that through the process. So after an initial planning stage, we then set about on the diagnostic phase, and this was about getting an understanding of how developmental services are provided to children around the state. So you can see that for a child who might have open heart surgery in the first 12 months of life, across the continuum there's a wide range of services that you may access in supporting your child's development. And this is from primary health providers like GPs and child health, all the way through to disability services and NDIS. We wanted to understand those services, and we also wanted to understand consumers' and families' experiences with these services. So we spoke with a lot of people. We had workshops. If anyone in the audience completed our survey, thank you. And you can see that consumers played a significant role in this project. So we've had consumer representation on the steering committee, and of the 5 consumers who've been regularly involved in the working groups, 1 family is pre-Fontan, 1 is post, and we have a young person living with a Fontan circulation heavily involved. Something else that we did that was also really, really valuable for us was to do some more in-depth journey mapping with families to get a much more in-depth understanding about what their experiences were, particularly in accessing services, but also around the communication that happened between services, to have a better understanding of that. And so after we did a whole body of work, put that all together, we identified 3 key issues. So if we look at the issues around service provision throughout the journey, firstly that there's no clear clinical pathway within Queensland Health for children with not just congenital heart disease, but any child who's has some kind of, makes them at risk from the early childhood period around their development. It's not clear for GPs what their role is in supporting children with heart disease around their development. As we mentioned, there's 16 HHSs all over the state. There's different eligibility criteria to get into those services. There's different services that are offered. And that's not always easy for families to navigate that and to be able to access the services that they need. So we looked at also the issue around caregiver knowledge and skills, so that we know that families need support and information to be able to develop their own knowledge and their understanding, and to be able to advocate well for their children, to access services. And in terms of information that's available to families around neurodevelopment and congenital heart disease, that's not always readily available or in a way that's easily accessed and understood. And looking at patient and family-centred care, we identified issues around ways that services are delivered and ways that services information is communicated that doesn't always keep patients and their families at the centre of that care. This was also an area where we identified around ways that we could improve in terms of supporting the mental health and the well-being of patients and families. So you don't just identify all the issues, it's then coming up with solutions to that. So we went back to our trial sites, to our consumers, and had multiple workshops and interactions to then start to look at what are some of the solutions and strategies. So only 6 solutions. So what we were able to do was to take all of those ideas and to identify the key areas and how we can start to move forward in what we think that will best support families in supporting their children's neurodevelopment. So importantly within our program with CHD Life, we need to be partnering and to continue to build on the partnerships that we have within the inpatient space. What we clearly saw is that development and long-term outcomes is not always on the agenda within the inpatient space. So there's certainly work we can do there to improve that. We're looking at establishing a statewide pathway, and also in looking at ways that we can continue to drive statewide advocacy and capability building. This is about putting congenital heart disease on the agenda out in the community. So what was very clear is that for a lot of community services, there's not a clear understanding about what impact congenital heart disease, particularly complex congenital heart disease, can have when they're trying to support your children. The service that we were providing is centralised here in Brisbane. This is a large state. We need to be able to be sure that families can access the support that they need within their local area. And again, this is about making sure that congenital heart disease is on the agenda out in the community. We want to be able to support families so that they're actively involved in their understanding. You are the ones who are at the centre of your children's care. Parents are the best advocates for their children. And again, as I mentioned, around being able to support the mental health and the well-being of families. We're starting to understand the impact that your journey has on your lives, and we need children grow up within families, and we need to be able to support parents and families as much as the children. So this is the governance for our CHD Life program. As we reach the end of this project, this finishes at the end of this year, and we start to implement those solutions, but we need to be able to continue and carry on the solutions that we've identified. So we first launched into this wanting to improve the sustainability, and that's what we need to be able to continue to do. And what's been really important that we've really understood through this body of work is it can't be done in isolation through the cardiac service. It's partnerships that are so important. So we partner with the clinical support within the hospital to be able to provide support that inpatient care. We partner with the Child Development Service to have our CHD Life clinic here. So this is in the past where our clinic was mainly involving young babies as they were discharged from hospital. This has seen a complete change in the way that we will probably run our clinic. What is the clearest deficit in terms of what's provided for community services is for older children. And we know there's difficulties for children can emerge over time. And so for children at key transition points like school, starting primary school, starting high school and transitioning into adult services, in terms of supporting development, there's not a lot of services there, and we want to be able to provide a service that integrates and understands around the medical, neurodevelopmental and psychological impact. We've always had wonderful relationships with Heart Kids, and where we've had consumer representation on our project, we want to continue to have consumer representation to sit at the leadership table of this program. So as much as we've relied on partnerships, like everyone else, we rely on funding. So if we want to be able to deliver this body of work, and I think what's been really important is to understand the work that needs to be done to support neurodevelopment and quality of life should not be seen as an added extra. It needs to be at the core and to be a core business of what services are providing, and it takes funding to do that. So everyone have acknowledgements. The financial support that we have had through the Health Improvement Unit and through Heart Kids, the program, our CHD Life program team, have very hard-working project officer, Miranda, within this project and the whole committee and working group, and to the consumers and families. We're very, very grateful for the support that you've provided us already, and you're the reason why we do this. Thank you.